Hello, everybody. My name is Garrett Schmidt. I am the managing editor for ACOexhibithall.com. I'd like to welcome you all to today's webinar that's hosted by PointRight called Post-Acute Analytics, What's in it for my ACO? So I'm very excited to hear about this topic, and also from Ms. Savage, who I'll introduce in a moment. A few items of note before we get started, some housekeeping stuff. Everyone who's joined today is in listen-only mode, so you don't need to worry about muting your microphone. That's all been done for you. And the webinar is being recorded, so if you would like to watch it afterwards, and we hope that you do, and share it with colleagues and clients or whoever you would like, I'm going to send you all, everyone who registered, I'm going to send you a link to the recording afterwards. And at that link, you'll be able to not only watch the recording, but also download the slides and visit their booth and do some other cool things. So I'll touch back on that toward the end here. And finally, during the webinar, we would love to hear from you. So please, please, please ask any questions that you may have. And you don't have to wait till the Q&A session in order to do so. You will have a little attendee control panel that just has a question module on it. So you'll want to ask your questions there, not in the chat, but in the actual questions section. And we're going to get to as many of those as we possibly can today during that allotted time. If for some reason we go over, we do have a lot of folks who registered and are in attendance today. So if we do go over and we're not able to get to yours, we definitely will follow up afterwards with an email. So don't worry. So please ask your question up until the very end. And at this time, I would like to introduce our speaker, Ms. Janine Savage, who's the Vice President of Product Management and Analytics and Business Intelligence with PointRight. And she has a very impressive CV, and she's going to give us a little more thorough overview of her bio and background. And at this time, welcome, Janine.
Thank you so much. It's great to be here. So I have a long history in healthcare, first as a provider myself and clinician, and then I found my passion in health information technology and led several initiatives in analytics and business intelligence. And I'm very happy to be with you today. So without further ado, let's get started and talk about analytics for ACOs. So today we'll talk about some of the types of analytics in post-acute care. We'll talk about how those analytics can help you build and sustain high-performing SNF networks, prevent readmissions to the hospital, and also prevent other types of adverse events, and help you reduce your total cost of care and ultimately earn more shared savings. Let's start out with a definition. So what is LTPAC? Long-term and post-acute care. Really, this is a wide variety and an array of services throughout the healthcare continuum. This includes services provided in specialty hospitals and nursing homes or skilled nursing facilities to home and community-based services. And we really think of LTPAC as a continuum of facilities, programs, and services for elderly and chronically ill populations. This includes facility providers like skilled nursing facilities, LTACs, IRFs, home health agencies. It also includes programs like home health care and hospice and PACE and adult daycare. So for today's discussion, we're going to focus mostly on skilled nursing facilities where a majority of the ACO post-acute spend is focused. When we talk about analytics, there are several kind of gold standard leading experts in the analytics world. One of those is Gartner, and they've built a very robust model about analytics. We look at the different types of analytics that are available, beginning kind of at the bottom left with descriptive analytics. Descriptive analytics tell us what has happened. It's data that's been analyzed, collected, organized, and summarized in some way. Typically, descriptive analytics, almost always, are historical and retrospective. And business intelligence fits into largely the descriptive analytics bucket, although we are beginning to see within business intelligence some other types of analytics as well. Descriptive analytics answer the question, what has happened? Sort of like looking in the rear view mirror. Diagnostic analytics tell us why something happened. It's built from and built on descriptive analytics and data. These are more advanced analytics. We perform data discovery, we mine data to find out the correlations to identify the root cause and answer why something has happened. So this is sort of like a human being getting diagnostic lab tests, except these things run automatically with the kinds of technologies we use today in analytics. Predictive analytics are also an advanced form of analytics, and they tell us what will happen. This is like looking forward in your car through the windshield. And predictive analytics are made possible by some of the technologies that we have available today. And increasingly, we're using things like artificial intelligence and machine learning to help us develop very robust and strong predictive analytics models. The next layer is prescriptive analytics. How can we make something happen? What should we do to change the course of what is likely to happen? This requires more advanced methodological approaches, and it tells us the best course of action to optimize our actions. In order for analytics to be useful, they must be valid, based in sound data science. They must be relevant to the area that we're applying them, and they must be actionable. There has to be something that we can do, an action that we can take or not take or change in order for analytics to be useful and to have value. There are, we could speak for hours about the different types of data analytics services and technologies and methodologies that are available. That's out of the scope of today's discussion, but you'll see that there are a lot of words in this word cloud that are floating around there because people are beginning to realize that analytics is the key to helping us change the course of healthcare outcomes. The different application areas that are used in healthcare organizations, including long-term and post-acute care healthcare organizations and services, include all of the ones that you see on your screen. We've been using financial analytics for many years, probably the longest of all. And those financial types of analytics give us insights into our accounting and finance and operational areas. Clinical analytics help us understand how we can better care for patients and make better clinical decisions. Business operations typically kind of brings those two together to give us insights into how to better run our business and merging some of the other areas. If we look at kind of that middle tier, human resources and risk management are emerging as areas that are important to analytics, helping us understand the insights from the source systems where we're collecting that type of data so that we can identify and mitigate potential legal, compliance, and financial risks. We also have quality analytics now, and that's becoming increasingly important along with value-based care analytics as we transform our healthcare system from mostly a fee-for-service environment to value-based care-driven initiatives and actually paying for quality and outcomes. And of course, that's what ACOs are in the business of doing, is participating and really leading that transformation in how healthcare is delivered. In order to be successful with quality and value-based care, analytics are absolutely essential. In fact, there's a really strong statement that the leading edge CAST data analytics primer includes that says healthcare providers who succeed under value-based reimbursement realize the power of an effective data analytics strategy. Not only providers of care under value-based care programs need to employ analytics, but the payers of care. And you're going to see today some examples of how payers and providers can share views into analytics that increase transparency and collaboration and improve outcomes. And also referral and population health analytics, two areas that I'm sure you're already familiar with, help us understand the patterns in transitions of care and the patterns of healthcare delivery and insights into healthcare delivery for certain populations of patients that we know are important to the overall healthcare spending and outcomes. So the data sources for these different types of analytics are wide and varied. Everything from claims and EHR systems to other types of transactional systems that providers use and collect data in, and that you yourself collect data. There are also standardized regulatory assessments that some of these providers complete. Standardized data is always an advantage because it eliminates the need to do those extra data curation steps to make sure we have good quality data. There's financial system data we collect, marketing data, and increasingly there are some new sources of data that we didn't have before. New public health data sets on social determinants of health, data that's collected through telehealth and remote patient monitoring technologies. These are all giving us great data, but as you're probably aware, we can be drowning in data, but starved for information. So analytics helps solve that problem. Analytics and meaningful analytics helps us achieve the goals of the AAA. The first one being care, improving patient experience, improving staff satisfaction, improving health, improving outcomes, preventing adverse events, and better managing populations that we know may have a disproportionate effect on healthcare outcomes overall. And cost, ensuring for providers that their reimbursement is compliant, for payers of care specifically, impacting the total cost of care by managing risks, decreasing readmissions to the hospital, managing length of stay, and managing utilization of healthcare dollars and services. And for any organization, increasing operational efficiency to improve their overall financial health of their organization. For many years, I was in a not-for-profit healthcare provider organization as an organizational leader. And I used to say, in order to meet the mission, we have to make the margin, because that's how we provide healthcare to the people that we serve. Different organizations may have different levels of analytics maturity. In fact, they definitely do have different levels of analytics maturity. And I'm sure you've seen the curve on the bottom. We call that the adoption curve. And many organizations are innovators in some of these areas of analytics and early adopters. Many organizations are laggards or are reticent to adopt analytics. We also see the hype cycle that's on the top. And we see that initially in an organization, sometimes there's a very high level of expectation about what analytics might do and what other technologies might do to help an organization. And sometimes, you know, that will peak and then we'll get to a real low after that when they realize that that is not the answer, the end all be all in and of itself. So what analytics can help do is flatten that out, and really implementing analytics in a thoughtful way can help sustain not only improvement, but performance over time. And that's always the goal for us, is to help our our providers and our payers implement analytics in a way that will help them not only improve but sustain performance. And that's a really, really key expectation to set. So now let's talk about, we have a little view of the kind of landscape of analytics. Let's talk about specifically how some ACOs are using post-acute care analytics to help further their goals and improve their performance. The first area that we're going to talk about is building and sustaining high-performing SNF networks. In order to deliver post-acute care in an efficient and effective way, the skilled nursing facilities that you work with need to be high-performing. What do we mean by high-performing? Well, getting good outcomes in the areas that matter the most. And we're going to share with you some areas that we think are particularly important. So when you're initially building your SNF referral network, there are several factors that are important in building that network of providers. Ensuring that you have enough providers in your service area so that you can meet the needs of your members, including ensuring that you have providers that provide any specialty care, right? And it's also important to know if those providers in your network are providing care with the outcomes that you expect and that you need. So we've identified 7 important domains of performance that we think are the most key, including rehospitalization, but also clinical and quality measures. CMS 5-star performance is important to evaluate, but we know from our studies that CMS 5-star performance is not necessarily correlated and aligned to some of the most important outcomes to ACOs and payers. For example, there's not a clear correlation always with CMS 5-star and rehospitalization or length of stay or some of the key quality measures for short-term rehabilitation patients in skilled nursing facilities. Regulatory compliance is important. Consumer experience is also important. So having a very balanced view of performance outcomes is the first key to successfully implementing analytics to build a SNF referral network. And assessing performance of that network really involves 3 things. It involves identifying areas where there are strengths and areas for improvement, and also identifying areas where you may have best practices that can be shared with others. In the ACOs that and other payers that we've worked with, this has been key to their success. We always tend to focus in on where performance needs to improve. That's where our attention tends to go. But sometimes we forget to look at the best performers and to find the lessons learned there so that we can share those lessons with others. And what well-designed analytics do, in analytics that are presented in a way that they are actionable, is to identify those areas so that you can bring that collaboration and transparency in those discussions that are more meaningful. And identifying areas for quality improvement initiatives is also important. I'll share a story from one of our payers. They typically get their skilled nursing facilities together every quarter, and they always pick a topic. And of course, that's been virtually over the last 18 months or so versus in person, how it typically was conducted. But even throughout the pandemic, they've been able to get their providers together on a quarterly basis, and they always pick a topic of interest that will help educate and inform the skilled nursing facility providers, targeted to an area of performance that needs improvement across their network. So for example, sepsis management has been a topic that they've addressed about a year ago. That was a big topic. Most recently during the pandemic, they used some analytics that we provided on COVID to focus in on some areas that they thought they could help the skilled nursing facilities improve related to COVID testing. Understanding a particular skilled nursing facility's key post-acute care outcomes compared to others is really how you evaluate that SNF's performance. And there are 4 key measures that we think are a good starting point for evaluating overall performance. And these measures really need to be, although some tend to look at measures like this in isolation, it's really important to look at these 4 measures in context and in relationship to each other, which is another example of why how analytics are presented is really the key. So annual post-acute volume gives you a barometer for how much post-acute care, i.e. skilled care, a nursing facility is doing. And the higher that is, of course, the more skilled patients that facility is caring for. And if that number is too low, especially compared to the peers and competitors in the market, then their outcomes need to be interpreted accordingly. The second area we look at is rehospitalization. It's important to look at an all-cause, all-payer, risk-adjusted rehospitalization measure. Risk adjustment allows comparison among facilities in a valid way. It also allows you to compare a facility's performance over time. Without risk adjustment, if you just do the simple math of numerator divided by denominator, where the numerator is the patients who went back to the hospital and the denominator are the patients who were admitted to the facility, then you're not accounting for very key differences, and that is not a valid way to compare facilities or even to compare a facility's performance over time. So a risk-adjusted, validated measure like the NQF endorsed measure we offer is really key. The adjusted, again, risk-adjusted median length of stay, that allows you to compare facilities' performance and length of stay to each other. And the risk-adjusted return to community measure. This is the percentage of the risk-adjusted percentage of patients who return to the community after a short-term stay in the nursing facility. And then being able to compare facilities' performance on each of these measures compared to each other, and to see how your network of providers stacks up in each of these 3 ranges, the favorable, the unfavorable, and the middle watch area, is also very beneficial to assess the performance of each skilled nursing facility. The second area that we're going to talk about is preventing hospital readmissions. We all know that hospital readmissions increase your total cost of care, and the cost of most of those hospital readmissions, as we're hearing from our payer collaborators, is rising. So it's always been important to manage readmission outcomes, but it's probably more important now than ever. So being able to, again, review the risk-adjusted measure is important. We also, in terms of valuable, interpretable analytics, we provide grades that are relative to a specific group of skilled nursing facilities. So within that group, we grade the providers for a valid evaluation of performance within that group. And it's one thing to look at rehospitalization performance overall, but it's even more valuable to be able to look at performance in certain key clinical cohorts. For example, heart failure, COPD, stroke, pneumonia, diabetes. This tells us how a facility is managing rehospitalization for groups of key patients with a certain clinical condition. And to benchmark performance is also very key. So here's a high visualization view of how the entire group is doing with a risk-adjusted readmission rate overall and by clinical cohort. And then we can see how many facilities are in each of these 3 cut points. And then that allows us to focus in on facility performance. And again, as I mentioned earlier, we always kind of gravitate toward these facilities that are in the red, right? But let's also not forget that it's important to look at the facilities in the green, because there may be best practices there that can be shared with others. And that's where improvement is really facilitated, is in the sharing of those best practices. So as we focus in on facility performance, we want to start at a higher level and progressively drill down. And you want analytics that are designed to do that. So addressing the drivers of a facility's performance is enabled when you have the proper analytics to tell you what those drivers are and to give you insight into that. We generally see that most facilities are good at managing certain cohorts of patients and struggle with other cohorts of patients. It's rare that there's a facility that is absolutely good at everything or absolutely bad at everything. There's usually something that they're doing well at that can be leveraged to improve the other areas. We also notice that because we risk stratify, so we stratify all patients into a high, medium, or low risk group, and we look at performance for high, medium, and low risk patients. And sometimes we will see that it's the low risk patients that are most challenging for providers. Sometimes they do really well in managing high risk patients because those patients tend to have risk factors that are more obvious, and they may be on a frequent assessment list where the nurses are more frequently assessing them. But sometimes it's the low risk patients that are actually driving up the overall rehospitalization issue in a facility. We also do things like converting a rate to a percentile so it's easier to interpret, right? So effective analytics help drive you toward effective insights so that you can take action. By looking at this percentile, I know much more quickly than trying to analyze rates compared to each other where this facility is not performing as well and where they're doing better. Next, we'll look at reducing the total cost of care. So in order to build on what we've already discussed, facility performance overall, then we need to look at how we manage high-risk patients, or for you, high-risk members. And the key to doing that is identifying individuals who have risk for adverse events and making sure that we have modified the things that we can that are causing that risk, or eliminate them if possible, or manage any associated complications, and also have the appropriate conversations with patients and their families to make sure that we're on the right track with the pathway of care for that patient, and that we're planning care and interventions that are in alignment with their wishes. So we provide patient-level predictive and descriptive analytics that include descriptive analytics on ADL and functional status, cognition, mood, and pain, as well as predictive risk analytics, risk-based analytics. So the likelihood that this patient is going to have a fall, develop a pressure ulcer, be hospitalized, die within the next 6 months, and if they are discharged to home or the community, the likelihood that they will return to a SNF in the next 12 months. We also provide the drivers or the covariates or the factors that are impacting these levels of risk and really driving the likelihood of these events occurring in the future so that those can be addressed by the staff, by the medical providers, by the nursing staff, by other interdepartmental members of the interdisciplinary team in order to help prevent these adverse events. And also for ACOs, the key to using these analytics is looking at the same information that the nursing facility staff is also looking at to collaborate effectively on the care management of these patients. Particular to identifying end of life, we know that there are many, many patients who are actually at the end of life, but that has not been identified. Perhaps they don't have a terminal diagnosis. Perhaps they've had multiple rehospitalizations, multiple hospitalizations over the last few months. There are other factors that can be contributing to the fact that they are actually at end of life, but it may be difficult for clinicians to identify that. Our predictive model helps the patients in the skilled nursing facility, helps the clinicians, I should say, identify patients that are at end of life. So those care planning discussions for advanced care planning can take place, and perhaps a more appropriate pathway of care, including potentially a hospice referral or palliative care consideration, can be done. Managing length of stay and achieving successful discharges from the SNF is also a real key area that analytics can inform. So by looking at the risk for hospitalization, the risk of return to SNF if the patient is discharged to the community, and looking at their discharge complexity, and that is the factors that must be successfully managed in order for them, number one, to make a transition to home, and number two, successfully stay in the home without either returning to the SNF or going to the ED or the hospital. Those are the key factors that must be managed at transitions of care. And again, this is an opportunity for the skilled nursing facility team and the ACO team, care managers, to collaborate effectively, looking at the same information, playing by the same playbook in order to successfully plan care and interventions for the patient and the member. So ultimately for the ACO, what does all of this action and collaboration achieve? And for ACOs, it's earning more shared savings. We know that there are much more opportunity to capture more shared savings for ACOs by reducing total cost of care to manage SNF networks. 50% of ACOs don't earn shared savings. We know that readmission rates among skilled nursing facilities, some of the nursing facilities participating with ACOs, is much higher than the national average. We know that costs are concentrated in high-risk patients, the neediest patients, the most expensive patients are a disproportionate, taking a disproportionate amount of the healthcare expenditure. And we know that ACO earnings can be very significant if these things are managed. And we have a track record for helping ACOs do that through analytics. We've helped our ACOs achieve over $101 million of Medicare savings and over $57 million in shared savings through MSSP. We have helped our ACO customers reduce rehospitalizations One of them has achieved a 25% reduction in 30-day rehospitalization. We've helped them reduce their SNF length of stay up to 14%, reduce their costs in their SNF PMPY expenditure and an overall decrease in SNF costs, and earn more shared savings. And in general, how do we know what the value of analytics is? We know the value because we ask end users and decision makers. And if you ask them, they will tell you how they're using the analytics, how they're acting on them, why they find them important and valuable. And the themes that we find is that users want analytics that are simple, that are visually helping them connect the dots, that help them, they need support. Very often ACOs and payers are not as familiar with the skilled nursing facility environment and how care is delivered and what the challenges in the skilled nursing facility environment is. So along with the analytics, it's important to provide that support and expertise to understand why certain outcomes may be happening and what questions to ask, how to engage with the skilled nursing facility effectively to have more meaningful conversations. That's an incredibly powerful thing to be able to do. And this quote from one of our customers, I think, really sums it up, not just about us, but about how using analytics can be the most effective thing that you can do. And it's having real-time quality outcome data, being able to drill down by disease, condition, quality measure in a way that you want to look at the data that's important to you. You know your organization, you know where your pain points are from other data and analytics that you're collecting, including claims data. You know where you need to work in order to drive improvement and be more successful. So analytics about post-acute care can help you complete that picture of nursing home quality and performance to actually drive improvement. And at this point, I'd like to bring Garrett back and we'll open this up to Q&A.
Okay. All right. Well, thank you so much, Janine. That was a really a great presentation. We do have a number of questions that have come in, so in no particular order, I am going to ask some of those here. And if you have questions, please go ahead and ask them at this time, and we will get started here. So the first question is, let's see, is there one measure to hang your hat on when evaluating your post-acute partners?
Is there one measure? Well, I would say that many people would say readmission, that's the measure, or length of stay, that's the measure. But we feel pretty strongly that you need to look at, as a good starting point, you really should look at the four key post-acute care measures that I discussed, which is the post-acute care volume, risk-adjusted rehospitalization, risk-adjusted return to community, and risk-adjusted length of stay. And looking at those four measures in context and in the context of performance both within a facility and those four measures compared to each other, as well as the context of that facility's performance within its peers. Those are the real key places to start.
Okay, great. Second question is, how do analytics tools like these help manage the relationship between acute and post-acute providers?
So that's really, I think, one of the key areas to focus on, because the relationship, it's kind of the whole carrot versus stick question, right? And you're going to get much further in a collaborative, supportive approach with skilled nursing facility providers than with a punitive, or otherwise approach. So being able to have a meaningful conversation and having analytics to focus on to facilitate that conversation, I think can be very helpful. And that's what ACOs have shared with us, is that having the information from analytics to start those conversations and actually improve the quality of their relationships with the skilled nursing facilities is the start to improvement. So I think that analytics can help facilitate that in a way that other data analysis can't. Because what the analytics will allow you to do is to get insights into the drivers of the outcomes. And that takes the conversation much, much deeper than staying on the surface of, just what the rehospitalization rate is, for example. But being able to say, I can see maybe you're struggling in this area, this clinical cohort, patients with diabetes, but you're doing really, really well managing patients with heart failure. What are you doing effectively, do you think, for patients with heart failure that maybe we could apply lessons learned to the diabetes patients? What do you need to better support you? And what can we do to help you with patients with diabetes? It really has a way of framing the conversation differently. And I think that's really the key.
Okay, great. And just another question, how open are the SNFs to sharing this data?
Oh, that's a great question. So probably the right answer is it depends, and it depends on a number of things. It depends on the approach, right? Everyone universally is always about what's in it for me, right? What's the value to me? Are you wanting this data from me to create these analytics because you're going to use it against me? Or are you, why do you want this data from me? So the answer to that question and how it's approached is very, very important to how receptive the skilled nursing facilities are. Our skilled nursing facilities tell us all the time that we are a great value to them because we help them do things they would not otherwise be able to do, right? So we really leverage the value that the skilled nursing facilities get from these analytics as well as the payer. And that's really why we encourage payers and providers to be looking at the same analytics, playing by the same playbook. And that really goes a long way versus, if a facility perceives that you have information that they don't know about, they're immediately going to be on the defensive about that. So transparency really is key.
Great. This is a question that came in and I hope I'm reading it correctly. Are facilities that are doing well on some things and not others, is this stable over time for a given facility? Example, is it just a sign of random variation?
That's a great question. So sometimes it is stable over time. There also can be variations, and one of the important things to look at is outliers, both outliers that are consistent over time and outliers that are restricted to periods of time, because the drivers of those events may be very, very different. For example, one of the things that may happen in a facility is when there is turnover of key positions, the administrator, the director of nursing, the MDS coordinator, we frequently see an impact on outcomes following those types of events. And then, if that's recognized, and this is one of the things that analytics helps you do, if that is recognized and addressed, you can course correct faster and get improvement back faster. Sometimes there is, consistency over time in certain areas where facilities are just not performing as well. Sometimes that's more often related to things like the types of patients the facility is taking. For example, we have facilities who have a very high behavioral health population. and they might not do so well in certain quality measures, like antipsychotic use, for example. So we may see patterns. So that's why it's so important to be able to see the drivers and drill down into the potential drivers of outcomes, because those two situations can have very different causes.
Great. And I see actually someone raised a hand, and I assume that's because you have a question. So there's you're on your control module, you should be able to ask a question there. So go ahead and do that, and we'll make sure to get to that. Okay, next question coming in is, it says, thanks for the insightful presentation. To what degree does a direction of causality get incorporated in identifying the drivers of performance? Do you include lost reimbursement or penalty for poor performance in the cost of readmission? I guess that's a two-part question.
Okay, so the first part, so causality. So where we can, in certain analytics, we identify potential causes of the outcomes. So, that is, one example is related to PDPM reimbursement. We really break down PDPM reimbursement to the drivers of the different components of reimbursement, and even what facility patterns or practices may be causing a certain component to be what it is in a facility. The second part of the question was, could you repeat the second part of the question?
Sure. It says, do you include lost reimbursement / penalty for poor performance in the cost of readmission?
So we don't currently do that. That's something that we've talked about, and we would need, more data in order to, more cost data and more collaboration with payers, something we'd be very interested in exploring further. Currently, we're not doing that, but that would be a very interesting area to go.
Great. Next question. We've got time for a few more here. How did you develop the algorithm for mortality?
So we use, we've had the mortality model for quite some time. It was originally based on a research project that was done, and we initially developed a logistic regression model. So we have over 25 years of MDS data, which is a great advantage because we can look at a lot of longitudinal data, and we have a lot of outcomes event data to work from to build our analytics models. We've most recently upgraded or updated our methodology to use AI and ML. So we've refitted those models using AI and ML methodologies. So that actually improved. We were already getting really, really good valid models, and that improved it even further.
Great. Next question is there one kind of machine learning model that you have found works better when it comes to rating clinicians on performance?
I don't think I could really speak to that because I am not the VP of analytics. So I know enough to be dangerous about these models, but not enough to speak about it intelligently. But we could definitely get that information back to the asker.
Okay, great.
You got to know, like one of my rules is, okay, you got to know your limits. That's where
only one person,
my limit
is. Okay, next question. Again, we have time for just a couple more here. Are there other ways besides transparency to build high trust relationships with SNFs?
Some of the other strategies that like our customers have shared with us, one successful strategy has been providing resources to the skilled nursing facilities in areas where they have pain points. Education on advanced medical technologies, for example. Another thing that they've shared with us is some ACOs have embedded nurse practitioners into facilities, and that's been very effective. And again, that's somewhat relationship based. Nurse practitioners are really great at teaching the staff and collaborating with the nurses, and that really raises levels of competency. And I think that's been a really, really effective strategy for some ACOs as well.
Great. Next question. Just keep rolling along. Considering most SNFs manage to the benefit are risk-bearing entities, closing the network to only SNFs that are, let's see, actually, I'm having a hard time with this one. Let me come back to that one. Next question here is, and I apologize for misreading that. Any thoughts on controlling for the difference between healthcare utilization and healthcare need, for instance, dealing with racial and other biases?
Yeah, social determinants of health and biases, this is something that we're starting to explore. We're, in all honesty, there is a lack of enough good data, I think, for us to, at this point, for us to have built into our models. But that's emerging, and that's growing exponentially, and something we'll definitely be looking at as we move forward.
Okay, great. And I'm going to attempt this question again. Considering most SNFs manage to the benefit, are risk-bearing entities closing the networks to only those SNFs that are managing to the plan rather than to the benefit? Does that make sense to you?
I think I know what the asker is getting at. So healthcare providers, let's just take an example. In a fee-for-service world for Medicare Part A nursing home benefit, right, there's no stimulus for the facility to limit the length of stay, really, in all reality. But under a managed care environment, then there is, because the payer is more actively managing length of stay. So I think that's what the asker means by the first part of the statement, providing care to the benefit.
Okay.
What we encourage people to do is, payers to do, is there's been this focus on narrow networks, right? So looking at hard cutoffs, you're in or you're out based on these outcomes. And we encourage them to be more, to do smart networks, we like to call them, right? So looking at those 4 key outcomes we talked about, not just rehospitalization or not just length of stay, but how those outcomes work together. And you need analytics in order to establish the relationship between some of these outcomes metrics. If you may have a provider who does better with length of stay, but maybe they have a very high hospitalization rate after that patient goes home, in which case you have not saved overall, right? You're spending more. So being able to kind of connect the dots there is really, really important to managing the overall total cost of care, and not being kind of tunnel visioned about certain outcomes with certain providers, but looking at it more holistically. And that may change the game for some providers who, based on a simple, length of stay measure, they're over the threshold, they're out of the network, but that there may be more information that's important to know.
Great. Okay, we only have time for one more, and I think this last question is actually a very important one. But if you have more questions, don't worry about it. We'll get to you via email afterwards. So please continue to submit them even as we're closing out here. But this last question for today is, what impact has COVID had on evaluating SNF performance?
Oh, that's a great question. We could talk for an hour about that, probably.
I'm sure.
But it's definitely had an impact. That goes without saying. It's increased the total, I mean, the data that we have and the feedback that we have from our customer partners is that it's increased the SNF spend in most cases. As we know, the providers are incredibly challenged, and it's increased their cost and also decreased their occupancy. So it's created a whole host of challenges. But the good news is that we have feedback from providers and payers alike that having the right analytics has really been key to helping them steer the ship through this storm as well as they have. In fact, we have one really strong case study that we've done with a provider in the metropolitan New York area. A lot of managed care, very high level of scrutiny on their outcomes. And they attribute their engagement with analytics to helping them maintain their performance despite COVID, through the pandemic. And I think that's a key takeaway, right? If you did not have that guiding light before, it probably would have been even worse for those providers. It probably was worse for those providers.
Okay. Well, great. Thank you. I think that's a good question for us to end on. And unfortunately, that's all the time we have for questions. So thank you so much, Janine. This was a wonderful presentation, very, very thorough. As we conclude, I wanted to encourage you all to visit the PointRight exhibit booth at ACOexhibithall.com, which is up on your screen right now. And this is where you can learn more about them, what they're doing, interact with their team. There's some downloadable documents, which, by the way, there is a handout, which I meant to mention at the very beginning of this session, that on your little attendee module, there's a handout where you can access the slides for today. So if you want to go back and where you can take notes, but don't worry, I'll be sending you the slides afterwards as well. But anyway, this is at ACO Exhibit Hall. This is where you can, again, interact with the team. Also, this is where you'll be able to find the recording. So in our library at ACOexhibithall.com, you can access the recording there and be able to find it after the fact. So with that in mind, thank you so much for attending. If you would like to get in touch with the PointRight team, you can reach out to Karen O'Driscoll, and her email is here on the screen, and she'll be able to help you and guide you and get you where you need to go. So feel free to make a note of that and get in touch with her directly, and she'll be happy to follow up with you for further discussion. So thank you so much, everybody, for coming. Thank you, Janine. Stay healthy and safe during this time. Have a good afternoon.
Thank you. Bye.